So good afternoon. I would like to thank HealthTree for organizing this wonderful event and all of you all to being here on a Saturday afternoon. So I'll go over briefly the process of CAR T-cell therapy. I'll also be touching on the CAR T-cell products that we have available for use in the clinic and also select CAR T-cell products that are under investigation. I'll also briefly touch on some of the short and long-term adverse effects of CAR T-cell therapy for myeloma. So what is CAR T-cell therapy? So all of us have heard of T cells. So T cells are immune cells that we all have in our body. So these are important part of our immune system. The T cells have this ability of recognizing abnormal cells, be it infected cells or cancerous cells, and they just are able to kill off these cells. So the T cells are responsible for regulating our immune system as such. So CAR T-cell therapy is pretty much harnessing the body's immune system to kill off the cancer cells. So in CAR T-cell therapy, we harvest a patient's T cells, we engineer them to find and kill off the cancer cells. As shown here in the cartoon, these cells are engineered in a laboratory where they are infected with inactive viruses that can insert certain genes into the T cells. So the genes will cause these T cells to express certain receptors that are directed against abnormal protein on the myeloma cell. So these T cells or CAR cells or super T cells are now able to find and kill off the cancer cells. So CAR T-cell treatment is an individualized treatment. So we actually collect the patient's own T cell. So the first step is collecting these T cells. This is what we call apheresis, where we specifically collect the T cells of the patients, and then it is shipped on to the lab where they are pretty much engineered to make them the super T cells. And further, once these T cells are ready, they are shipped back to the infusion center where we administer it to the patient. The CAR T cells have the ability to bind to the cancer cell and kill them off. I also want to introduce this term BCMA or B cell maturation antigen. So the CAR T cells are directed against antigen or abnormal protein of interest. In the myeloma space, BCMA or B cell maturation antigen is the most common target in the immunotherapy space. So this slide actually shows an overview of the products that we have available in the clinic. So currently we have 2 FDA-approved products for use in the clinic, ide-cel or Abecma and cilta-cel or Carvykti. So these were initially approved between 2021 and 2022 for use in myeloma in the 5th line. That means our patients have to go through 4 different lines of therapy to be able to get this treatment. In 2024, we have approval for these therapies in the earlier lines following the positive results of the pivotal clinical trials. So we have CAR T-cell therapy available for use in earlier lines. In fact, cilta-cel is available for use in the 2nd line, and ide-cel is available for use in the 3rd line. So pretty much CAR T-cell therapy is available for use in the earlier lines as of now. I want to briefly go over some of the clinical trials that led to the approval of these products. So the KarMMa-3 is a big phase 3 randomized study. So this study included patients who've got 2 to 4 prior lines of therapy. Patients were randomized to ide-cel versus standard of care option. In this study, patients who were able to get ide-cel, as you see in the figure here, had an overall response rate of 71% compared to 41% in the group that got the standard of care option. And ide-cel in the study was able to keep our patients in remission longer than the standard options in the control arm. So following the results of the KarMMa-3 study, ide-cel is now available for use in the 3rd line for our patients who've already got a prior immunomodulatory agents, that is either Velcade and Revlimid. Proteasome inhibitors are our pomalidomide and lenalidomide, and a CD38 monoclonal antibody, daratumumab or cetuximab. Just briefly going over the results of the CARTITUDE-4 study. So this is again a big phase 3 randomized study that investigated cilta-cel in patients with relapsed refractory myeloma. In this study, patients who've got 1 to 3 prior lines of therapy were randomized to cilta-cel versus the standard of care options. So cilta-cel was able to induce an impressive overall response rate of 85%, and the CR rates were also higher in patients who got cilta-cel, as shown in the green box plot. Again, patients who've got cilta-cel had a prolonged remission compared to patients who've got the standard options of pomalidomide, Velcade, dexamethasone, or data pomalidomide, dexamethasone in this study. So following the positive results of the CARTITUDE-4 study, cilta-cel is also approved for use as early as second line in our patients with relapsed refractory multiple myeloma as of April 2024. I also want to briefly touch over some of the select CAR T-cell products that are on clinical trials. So anito-cel is another BCMA-directed CAR T-cell therapy that is currently under investigation. So this particular CAR T product has a unique D domain, as shown in the by the arrow there. So this D domain can enable us to give a lower cell dose of the CAR product, and this may allow us to kill off the cancer cell without prolonged inflammation, and thus this may have a better safety profile compared to ide-cel and cilta-cel. Again, the early phase trial did show that nearly all patients had a response, and about 60% of this was complete response. And interestingly, in this study, we did not note any long-term neurological toxicities. I'll be going over the neurological toxicities in subsequent slides, but then we have noted that our patients can develop delayed neurotoxicities such as Parkinson's, cranial nerve palsies, Guillain-Barré, etc. These are rare, but they are real. So with this product, at least in this early phase study, we did not have any of those events. So all the CAR products that I discussed before are directed against BCMA. So as with any therapy in myeloma, there is going to be disease resistance to a given therapy, and none of these treatments are curative treatments. So we always need other therapeutic options. And arlo-cel is an investigational CAR T-cell product that is directed against another antigen called GPRC5D on the myeloma cell. So shown here are the results of the early phase study. And as we see here, nearly half of the patients who were treated on the study got a prior BCMA-directed therapy. The overall response rate was in the late 80s and high 90s. So, and nearly half of these responses were complete response. So this is definitely an option for our patients who've got a prior BCMA-directed therapy, and this targets another antigen and kind of broadens the therapeutic options for our patients. So I'll go over the logistics of administering CAR T-cell therapy. So the first step is really to identify a patient who is eligible for a CAR T-cell therapy. So typically our patients are identified by our community colleagues and referred to a CAR T-cell center. So once we see our patients for CAR T-cell evaluation, the patients undergo disease evaluation, which is our standard labs for myeloma. We make sure that our patients get a scan, which can either be a PET scan, MRI, or a CT. And we always get a bone marrow prior to CAR T-cell therapy. This helps us understand not just the myeloma, but the overall health of your bone marrow as such. Our patients also undergo organ function evaluation, which includes heart and lung function, neurocognitive testing, frailty testing, and psych-onc evaluation. So CAR T-cell therapy is actually a very complicated multi-step process, and it really takes a team to get our patients to CAR T-cell therapy. So we make sure that our patient is in touch with a CAR T coordinator. We make sure our patients get insurance approval prior to the process as such, because this as such is an expensive procedure, and the treatment alone is currently $500,000. So our patients get to see a financial counselor. In addition, this is a treatment where our patients have to stay close to our center for about 4 to 8 weeks. So they will need caregiver support 24/7 for at least the first 4 weeks. And currently, the FDA, they recommend no driving for the first 8 weeks following CAR T-cell infusion. So we need to make sure our patients have a designated driver for all those follow-ups. So the next process is the CAR T-cell creation and treatment process once we have identified the patient and the patient is eligible and have gone through all the testing. The vein-to-vein time is actually the time from apheresis, that is the T-cell collection, to the time of actual CAR T-cell infusion. Typically, the vein-to-vein time takes about 6 to 8 weeks. So the first step here is to now collect the T cells. That's what we call apheresis. So apheresis is pretty much harvesting the T cells. So our patients come in, they get a central line placed into one of the veins in the neck. And then they are attached to a machine that looks like a dialysis machine, which pretty much collects the T cells. And this is usually a one-day process. We make sure that the line is placed in the morning and the harvesting starts late morning or early afternoon, and everything is done in a single day. So that's convenient for our patients who have to travel long ways to come to our center. Most of the time, one apheresis is all we need, but in about 5 to 10% of patients, the T cells cannot be manufactured for various reasons. This could be because of insufficient quantity of the T cells recovered, or it could be because of issues with the engineering process as such. And so in that case, we will have to bring our patients down for a second apheresis. That's why I tell that CAR T-cell therapy is a very complicated process that takes a little bit of time to really organize. And this is not something that we can promise to deliver in about a month. That's really not going to happen. So the next process, once the T cells is collected, is to engineer them. So pretty much the manufacturing process involves infecting the T cells with inactive viruses to insert genes into the T cells. The genes will pretty much cause these T cells to make special receptors called CARs, which are directed against the abnormal protein on the myeloma cell. And then these super T cells are then optimized in the lab, and then they are shipped back to the center where they are administered to the patient. I also want to highlight here that different products are expanded to different specifications, and this kind of can differ between the two products, ide-cel and cilta-cel. So once the cells are delivered, they are stored, and then we find a good time for our patients to come down for this process as such, because again, once the patients come down, they are with us for about 4 to 8 weeks. So we want to make sure that we, give them adequate time to prepare and all that. So once the cells are stored, they're actually good for about a year. And then once the cells are thawed, they are actually infused within 2 to 3 hours. So I also want to go over bridging therapy. So we know that currently the process of the apheresis to infusion will take about 4 to 6 weeks. So in between, some of our patients need to be on some kind of myeloma therapy to hopefully stabilize the disease. And that is what we call bridging chemotherapy or debulking chemotherapy. So the idea of starting this is mainly to debulk or at least reduce the disease burden. Some of our patients may go into a disease remission, but then the whole idea here is to pretty much stabilize the disease so that we can safely take our patients to CAR T-cell therapy. And this is very different from the chemotherapy that we give prior to CAR T-cell infusion. So lymphodepletion refers to the chemotherapy that we give just before the CAR T-cell infusion. So this is separate from the bridging therapy. So the idea of lymphodepletion is that we want to make room for these engineered cells so they can expand. So this is different from the high-dose chemotherapy that our patients get when they get transplant. So the most commonly used regimen is a combination of cyclophosphamide and fludarabine. We've used bendamustine as an alternative, but the most common is cyclophosphamide and fludarabine, and we give it for 3 days, like day 1, day 2, and day 3. And day 4 is usually a day of rest, and then the CAR T cells are infused on day 5. So the infusion of the product, it again depends upon the product as such. We can infuse it outpatient or inpatient. At MCW, we have an all outpatient CAR T cell program. So all of our patients who get the standard of care, ide-cel and cilta-cel, they get it as an outpatient. So before infusing CAR T cell product, we make sure that we have tocilizumab, which is medication directed against IL-6, which kind of breaks the inflammation that occurs after the CAR T cell product. Our patients do get a pre-medication. We try to avoid steroids during that period. And the infusion as such is very brief. It's like 15 minutes and it's done pretty much. So I also want to go over briefly our program where we do an all-outpatient CAR T cell administration. So what we do for our patients is that we see our patients for an extended consent conference where we sit down and talk about all of these processes. We make a calendar for our patients. And then once we have identified the day they come down for the lymphodepleting chemotherapy, they are seen in our infusion center. They get the cocktail of cyclophosphamide and fludarabine. It's given for 3 days. And then the following day is the day of rest. And then CAR T cell is administered on day 5. And we make sure that we select the days in such a way that the day off falls on a weekend. We always educate our patients at multiple steps about the side effects, including cytokine release syndrome, ICANS. I'll be going over these side effects. But we have the ability of bringing our patients to our 24-hour clinic, which is housed within the cancer center. So we have somebody on call in the cancer center 24/7. So if a patient is calling in with complications in the middle of the night, we will have somebody talk to them. And if there are suspicions for CRS, we try to bring our patients, to be seen in the clinic right away. And we do have the ability of administering tocilizumab, which is the medication to break that inflammatory cycle. We can administer up to 2 doses as an outpatient, and we observe our patients for about 8 hours or so after administering tocilizumab. And if the symptoms resolve and if the patient is medically stable, we can transition back to our outpatient program. So we uniquely have this ability of doing it outpatient, and that kind of improves experience for our patients where they could remain outpatient for this 4 to 6 weeks. So I want to briefly go over some of the complications of CAR T cell therapy. So the early side effects include cytokine release syndrome or CRS, immune effector cell-associated neurotoxicity or ICANS, cytopenias, infections, etc. So the late complications, the important ones are mainly the cytopenias, infections, and delayed toxicities, particularly the delayed neurotoxicities such as cranial nerve palsies, Parkinson's, Guillain-Barré syndrome, and rarely second cancers. So cytokine release syndrome occurs when the immune system kind of overreacts and secretes a massive amount of this inflammatory cytokines, which are really the proteins that kind of mediate this inflammatory storm that happens in the body. So this is not unique to CAR T cell therapy. We've heard earlier today where this can occur with other immune therapies such as bispecific antibodies. So the key here is to identify these symptoms and act promptly. The symptoms include fever, fatigue, headache, diarrhea, etc. Late symptoms include organ failures such as cardiovascular collapse, pulmonary issues, and multi-organ failure. I want to briefly go over the pattern of CRS. It does differ depending upon the products. So as you see here, nearly all patients develop CRS. 84 to 95% of our patients treated with ide-cel and cilta-cel develop CRS. Fortunately, most of them are grade 1, 2, which is a milder grade. High-grade CRS, that is grade 3 and grade 4, is fortunately seen only in less than 5% of patients. The time to onset of CRS also differs across these products. It occurs early with ide-cel at a median of 1 day after infusion, and it's a little later with cilta-cel at a median of 7 days after infusion. And the symptoms of CRS kind of last between 4 to 5 days. The treatment of CRS is mainly tocilizumab, which is this drug that blocks interleukin-6, pretty much breaks the inflammatory cycle, and the second line is actually steroids. I actually want to just briefly go over how we manage CRS at our center. The first step is to make sure that we identify CRS, make sure our patients get adequate infection workup, including antibiotics, blood cultures, and all that. And then this is really CRS. We grade CRS grade 1 through 4. Higher numbers means high grade, lower numbers means low grade. So the first step is to administer tocilizumab. And if there is no improvement with tocilizumab, we promptly move on to steroid therapy. And we are able to do all of this as an outpatient because of the team that we have at MCW. Another important side effects that we have with a CAR T-cell product is the immune effector cell-associated neurotoxicity syndrome, or ICANS. So it's pretty much the syndrome of neurological side effects because of the cytokine or the proteins that are released as soon as the CAR T-cell therapy is given. So the mild symptoms can include confusion, vertigo, dizziness, etc., to seizures and coma, etc., in high-grade ICANS. So again, just like CRS, the pattern of ICANS also depends upon the product. We see here that ICANS is seen in nearly a third of the patients who've treated with ide-cel and cilta-cel, and high-grade ICANS, that is grade 3 and 4, is seen in less than 10% of patients who get these therapies. With ide-cel, we see early ICANS. The time to ICANS is about 2 days after the CAR T-cell infusion with ide-cel. With cilta-cel, it's kind of a late ICANS that occurs 8 days after infusion. And the duration of ICANS is usually 3 to 4 days. Steroids are really the primary treatment for ICANS. And again, this slide pretty much shows how we manage ICANS. The first step is to identify ICANS. The next step is to grade ICANS. It's graded grade 1 through 4, where the higher numbers indicate high grade and lower numbers indicate low grade ICANS. We also make sure that a patient gets appropriate scans like a CT scan or MRI. Sometimes we do a lumbar puncture just to make sure that we are not missing an infection or other causes that can explain the neurological toxicity. Steroids are the main first-line treatment for ICANS. And this complex algorithm really shows the how we manage ICANS, including escalation to other treatment when steroids don't work. So infection is another important complication following CAR T-cell therapy. Indeed, infection is one of the important causes of mortality following CAR T-cell therapy for myeloma. So in this recent study of nearly 7,500 patients with myeloma and lymphoma, they looked into the causes of death following CAR T-cell therapy. So these are patients whose disease is in remission, and we lose our patients to causes other than disease as such. So here we find that nearly half of the causes of death is because of infectious complication. And this is very important to keep in mind because infection can occur during the first 30 days. And in fact, infections can occur all throughout the first year following CAR T-cell therapy. And this is important because once we do the CAR T-cell therapy, we keep our patients close to our center for about 8 weeks, and we do follow very closely for the first 3 months, and then pretty much they transition to their local community oncologist where we co-manage our patients, but then infection risk is ongoing, and it's important that we identify infections promptly and act on it. I just want to highlight the infection prophylactic strategies that we have in place for our patients who receive CAR T-cell therapy. The one important thing I want to highlight here is that we replace immunoglobulin or antibodies for all patients who've got CAR T-cell therapy. So what happens with CAR T-cell therapy is that the treatment kind of eradicates the good and bad plasma cells. That means at the end of this treatment, our patients cannot produce any antibodies. For example, if they were to have an infection, usually what happens normally is that our bodies can produce antibodies that can help us with that infection, but our patients lose that ability because of these these therapies where they are very good at eradicating the good and the bad myeloma plasma cells as such. So we make sure our patients are on immunoglobulin supplementation or IVIG supplementation that starts about a month after CAR T-cell therapy and goes all the way through about a year or even till the serum IgG level is more than 400. So we make sure that this is in place, and this is something that they continue with their oncologist in the community. And of course, our patients are always on acyclovir. We make sure our patients are on PJP prophylaxis with Bactrim or an equivalent drug for about 3 to 6 months following CAR T-cell therapy. We also make sure we vaccinate our patients against COVID, influenza, and the other vaccines a little out of CAR T-cell therapy. I want to briefly go over some of the other side effects that we have seen with CAR T-cell therapy. So this is renal policies that we have seen, and this occurs in about 10% of patients. And unlike the ICANS or the early neurotoxicity, this occurs actually 3 weeks after CAR T-cell therapy. Again, this is important to know because once we have a patient who presents with a suspected cranial pulse, it's important that we rule out other causes and we start the patient on usually a short course of steroids. And fortunately, these are largely reversible with a short course of steroids. So movement and neurocognitive toxicity is another side effect that we have seen with the current CAR products that are available in the clinic. And this is seen in roughly about 6% of patients. And we see here that this occurs an average of 56 days after CAR T-cell therapy. So this is kind of a delayed toxicity. And this could range from mild movement disorders where the patients can develop speech disturbances, gait problems, or tremors to really personality changes or reduced attention span, memory impairment, etc. So once we identify any of these symptoms, it's important to do the adequate workup that may include imaging studies, lumbar puncture, etc. And unfortunately, we really don't have very good treatments for this. Steroids may not work for these conditions. So this is something that we keep in mind. And fortunately, this is rare. And there's a lot of interest in understanding what are the risk factors of these kind of side effects. And we may have found that having a high lymphocyte count, that is one of the blood counts, the first few weeks after CAR T-cell infusion may be predictive of neurological toxicities such as these. But then this is an area of active investigation, and currently we don't have a good way of treating these. I also want to briefly touch on secondary cancers and T-cell lymphomas that we've all heard of as a complication of CAR T-cell therapy. So when we see these data, we want to keep in mind that these are really patients who've got a lot of other treatment before they got CAR T-cell therapy. They've gone to transplant and other therapies that also can increase the risk of secondary cancers as such. So currently, we think that second cancers can occur in about 5% of our patients who are treated with CAR T-cell therapy. And the T-cell lymphoma, which was something that the FDA had issued a warning, is kind of rare, but it can affect a fraction of our patients, and this is something that we keep in mind when we discuss CAR T-cell therapy with our patient. And this is why we make sure that we do a bone marrow before CAR T-cell therapy, where we understand, are there changes in the bone marrow that can predispose our patients to this kind of secondary cancer. And we also make sure that we do a bone marrow day 100 post CAR T-cell therapy. And in some of our patients where the blood counts don't recover with time, we have a very low threshold to repeating this bone marrow and making sure that we're not missing another cancer of the bone marrow, particularly what we call myelodysplastic syndrome or MDS, which is indeed a precursor to acute leukemias. This is all I have for you. Thank you so much.